See, I always start this backwards. Okay. So today I'm going to talk about hydrocodone combination products, why they were rescheduled, and how that's really affected pharmacy practice. I'm going to go over the regulatory changes with the board rules that have occurred in the past year, and then briefly touch on the pregnancy lactation labeling changes that are coming up. So the DEA enforces the Controlled Substance Act, and per the Controlled Substance Act, every controlled substance falls into a schedule, one of 5 schedules based on their potential for abuse and dependence. And it's the DEA's job to really regulate, to prevent, detect, and eliminate when there's diversion that's going out into the illicit market. So because controlled substances do have that potential for abuse and dependence, the DEA controls it to protect the public health and safety. All right, so I don't know if anyone's recently taken the law review course, but this slide might look familiar. This is the definition of a Schedule II drug. It's one that has high potential for abuse, does have a medical accepted use in the U.S., and it has a severe physical and psychological dependence potential. So who has the authority to reschedule or change a drug between schedules? That's generally the Attorney General. So if he feels or sees that a drug does have high abuse potential and it's in a lower class of a drug, then he can move that. But in this case, actually, the Attorney General delegated that authority to the Administrator of the DEA, and the Administrator of the DEA actually has those same rights. So on her own motion, she can say, yep, we're going to reschedule this drug, or she can kind of go off of expert opinion, advisory committees, or from a petition of an interested party. So to give you a little bit of a background on how this all started, the rescheduling was actually initiated by a petition from a physician in 1999, and it wasn't until 2004 that the DEA even really acted on it. And at that time, they actually submitted a request to the Department of Health and Human Services requesting that they look at this and evaluate and make a recommendation based on this rescheduling. In 2012, President Obama signed in the FDA Safety and Innovation Act, and he requested that the FDA put together an advisory committee. They solicit information from expert opinions, even patients, so that they could kind of come up with an idea of what was going on with the hydrocodone combination products. And in January of 2013, the FDA Advisory Committee voted 19-10 in recommending the rescheduling of those hydrocodone products. And then in December of 2013 is when the Department of Health and Human Services came forward to the DEA and recommended that rescheduling. So at that time, the DEA said on this proposed rule they would take public comments, and they received a few. They got 573 comments, and 52% were in support of rescheduling hydrocodone combination products. And interestingly, it was the general public and physicians who really supported the rescheduling. 41% actually opposed the rescheduling, and a majority of those individuals were pharmacists, pharmacy students, and the ultimate users of the drug. So when rescheduling or considering scheduling of controlled substances, there's this 8-factor analysis that the Controlled Substance Act requires that you look at. And the Department of Health and Human Services submitted a scientific and medical evaluation document that included this 8-factor analysis, and this helped them to make that decision that it was necessary to move hydrocodone combination products into a higher schedule class. So these are some interesting statistics. Per the Center of Disease Control and Prevention, since 1999, prescription painkillers prescribed and sold have quadrupled, yet the overall report of pain has not changed. Hydrocodone is the most frequently prescribed opioid in the United States, with nearly 137 million prescriptions for hydrocodone combination products dispensed in 2013, and hydrocodone products were the most widely prescribed to Medicare beneficiaries in 2013 as well. So that's kind of shocking. You would think with that patient population it would be more of a maintenance drug, not something that's used for pain. So based on that information, the Department of Health and Human Services really had to look at the prescribing trends. Is this being overprescribed? Is there a false sense of security because it's in a lower schedule? So they looked at that. They took in public comments. They had the advisory committee, and then they really looked at the health risks and benefits. And with that, they came up with the decision that, yeah, hydrocodone products do have high potential for abuse. We know there's a medical accepted use, and because of that abuse, they do have the potential to lead to severe psychological and physical dependence. So obviously that is the definition of what a Schedule II is. So how has this really impacted pharmacy? And you guys probably know this better than I do, but there's lots of ways that it's probably really impacted pharmacy. And like all healthcare providers, pharmacists were really concerned. Are my patients going to get their medication? Are they not going to have controlled pain? So those were things that came about. And of course, the DEA's response was it should not change how prescribers are prescribing as long as it's for a legitimate medical purpose. And that's our job as pharmacists as well. We need to make sure that it's a legitimate prescription. The impact for long-term care facilities, there's always been accommodations per the DEA that allows long-term care facilities to get their pain medications. So they can actually fax in C2s, they can do limited supply, so partial dispensing of C2s. So there's always been kind of accommodations. Abuse prevention and diversion prevention. A lot of people said, is this really going to cut back? Are people going to stop abusing? And the DEA stance is honestly that we're overprescribing hydrocodone combination products. So if we can decrease the amount that we're prescribing unnecessarily, then we decrease what's out there. As Gina mentioned earlier, a lot of people are getting these medications from friends and families. So when you go to the dentist, you get a tooth pulled and they give you 30 hydrocodone. Do you go home and take all 30? No. It sits in your medicine cabinet and it has access to children, to families, to friends. And so that's what's kind of happening, and they're hoping that that will decrease that prescribing potential. Diversion. A lot of people said people are still going to steal the medications, and that might be the case, but hopefully with increased monitoring, increased safeguards in place, that will help decrease diversion as well. Then economic impact is probably going to fall primarily on the patients, because they're the ones that are going to have to go to the doctors more often to get prescriptions, so transportation costs, co-pays. Pharmacies really shouldn't have felt much of an economic impact. Yes, you have security safeguards that are in place, but this is one medication, so hopefully that didn't impact them too much. Requirements for prescriptions. In some states, only you have to use the triplicate prescription, so maybe that's an issue or a problem. And also mid-level practitioners can't prescribe C2s in some states, so those were some issues where the prescription issue became concerning. Responsibility of pharmacists, really it did become more of a burden of administrative duties. So now the technician is needing to input the order every single time the prescription comes through. Some states only the pharmacist can count C2s. There's more record keeping requirements. The inventory might be more burdensome because now you can't just estimate, you have to have exact counts. So all those things did play into account when this was switched over. All right. So now we're going to go into board rules, and some of this might apply to you guys because these were just the changes that occurred in the last year. A lot of it probably won't. The most important take-home point is that board rules always change. They don't just change annually. They don't change quarterly. They can change at any time. And we as pharmacists need to make sure that we're practicing under the most current rules. So if you have not already done so, it's highly recommended that you go to the state board site, get registered so that you can get emails every single time a rule changes so that you are practicing under those most current rules. So orders. So some of this was just kind of wording that kind of changed with some of these things, but this is for orders, what needs to appear on each order, and the purpose of this was just to really clarify the content that was required on each order. So obviously you need the date the order was compounded or dispensed, an assigned serial number. The exception here would be for hospital chart orders, a quantity dispensed if it differs from the quantity that was ordered by the doctor, and the exemption again is long-term care facilities. I've highlighted where the actual changes have occurred so that you can see that when we move from slide to slide. And then obviously for all of orders we need the patient address, prescriber's address. If it's a controlled substance, we want the DEA number as well. First dose dispensing, this is primarily for long-term care facilities. So if a long-term care facility is contracted with specific prescription drug outlet and they can't get the prescription to the patient in a timely fashion, they can actually use a duplicate copy of the long-term care facility chart order, give it to another pharmacy who can provide that medication in a timely fashion for immediate care for that patient. And this is just the information that needs to be contained within that. The change here was that they said that the pharmacy that's going to take and do the 72-hour supply of medication, that they use that duplicate as their prescription order, and it needs to comply with the requirements of prescription orders. So this was a new rule altogether, and this was for prescription drug outlets that were dispensing to other outlets. So if the patient did not come and pick up that particular prescription, this rule now says that that prescription can be returned back to the original prescription drug outlet for redispensing. So as long as they comply with the board rules, the storage conditions in transport to and from the other outlet does not in any way compromise the integrity or stability of the drug, and controlled substances, compounded drugs, as well as those that have been flavored cannot be returned to stock for redispensing. This is another new rule, and this is for registration for non-resident prescription drug outlets. And this is just to provide another way for a non-resident drug outlet to get registration regarding the inspection report. So if they don't have a way of providing the inspection report. So obviously you have to apply and pay the fee. You have to have verification of the pharmacy license or registration within the state or the resident state board of pharmacy, and you need a copy of the most recent inspection. And so that could be from the resident state board, or it can be from the National Board Association of Pharmacies as well. And then obviously there needs to be an affidavit stating that that non-resident prescription drug outlet will not ship drugs into the state of Colorado if they do not have a specific patient listed for them. And again, that's just to really prevent what happened with the New England Compounding Center. So the next three slides have the complete qualifications for pharmacists who practice CDTM, and the only one that really has changed is that one. So they can practice after just 1 year of pharmacotherapy experience as long as they have that on-site supervision of clinical practice and training in the area that they choose to practice in. So for the next two slides, I'm just going to breeze through those because that's just more for completeness. All right, emergency kits. So prescription drug outlets or hospital other outlets actually can provide emergency kits to certain facilities, and those are long-term care facilities, hospices, home health agencies, and the new addition is the acute treatment unit. And for those of you who don't know what that is, it's a 24-hour residential facility, and it's for people who are in need of short-term psychiatric care, but they don't really qualify for inpatient hospitalization. So it can treat certain conditions like behavioral health, mood, depression, personality disorders, as well as substance abuse. So this is for the category limitations of emergency kits. And for these particular facilities, so the long-term care facility, the acute treatment unit, and inpatient hospices, it's the medical director and the consulting pharmacist who determine the contents of the kits. And remember, these kits are only supposed to be for emergency supply. So they are limited to 60 drugs, 12 of which can be controlled. Each drug cannot contain more than 30 doses, and they are limited container size to unit of use or unit dosing. Record keeping. So this is inventory for controlled substances, and you'll see that the addition here is for pharmacies owned and operated by HMOs, and this is just pretty much including that when they do inventory, that if you have it located throughout the facility, so you have floor stock, that needs to be included into your annual inventory or biannual inventory as well. So records of distribution. So when those drugs get distributed out to the floor stock, that does need to be documented in some fashion, and the record needs to have detailed information, needs to be kept for at least 2 years, and the information it needs to include is the location of where the drug went, the drug strength, dosage form, the individual who sent out the drug, and the person who placed the drug into floor stock. So it has to be a very descriptive record. Other outlets, so Other outlets are, these are facilities that actually qualify for other outlets, and you'll see the acute treatment units as well as telepharmacies have been included in this. Telepharmacies are remote pharmacies, so they need to, at the time of registration, they need to be at least 20 miles from an original prescription drug outlet or other telepharmacy. And what they do is they link up by telecommunication to the central pharmacy, and a technician is on site at the telepharmacy, and they can be supervised by looking through that telecommunication, and they can perform certain tasks under the supervision of a pharmacist who's at the central pharmacy. So the consultant pharmacist is responsible for doing inspections, and they need to document inspections. And so again, it's just included the acute treatment units and telepharmacies into those inspections. And the inspection frequency is determined based on how many dispensing units the facility issues. So for this one, consultant pharmacists, obviously they're responsible for complying with board rules, but they really wanted to just point out that if any compounding, sterile or non-sterile, that does fall on the liability of the consultant pharmacist as well. Limited license. Now this is essentially like another outlet, but they have limited license because they can have possession of certain drugs. And this really used to focus on veterinarian practice, but now it's actually included the Colorado Wildlife Division as well. So it just says you can use certain drugs if it's for the purpose of capture, sedation, and mobilization of animals prior to euthanasia for injured, sick, homeless, or unwanted pets. So usually like the Humane Society. And then employees are authorized to capture this wildlife for animal control, management, research purposes. And then the drugs can only be purchased, possessed, stored, and administered by the outlet as long as it was obtained from an entity that was registered by the State Board of Pharmacy. The drugs do need to be secured. They need to be locked in cabinets in a safe, bolted to the floor, or other equivalent secure location. And the drugs should be stored at the location that's registered by the DEA. However, if the drugs are actually being transported, they need to be in the immediate possession of the employees, and they can only use them for, obviously, capture and mobilization of wildlife. So outlets are authorized to purchase, possess, and administer drugs, and it just kind of reiterates under what circumstances that can occur. And this is a list of acceptable drugs. The ones highlighted in blue have been the ones that have been added to the list within the last year. And these outlets do need to retain records of receipt, distribution, loss, surrender. That needs to be maintained at the facility. And they also need to make sure that they have some sort of training so they can say that the staff has demonstrated training to administer the drugs in which they were intended. The Pharmacy Peer Health Assistance Diversion Program is now renamed the Pharmacy Health Assistance Program, and the purpose of that is because they support more services now than just abuse and diversion. And these are two of the definitions that they've added to under this category. Central prescription processing. The purpose of the addition of this was to really define and address the practice of shared pharmacy services, and so they have also added some definitions. Central prescription processing contract. This is a written contract that outlines the services that are provided and the responsibilities, accountabilities of those that are involved in this process. The contract pharmacy is a pharmacy that is party to the same central prescription processing contract or another pharmacy performing any part of the fulfillment of the prescription order. The network pharmacy is pharmacies that are under the same common ownership or the same central prescription processing contract. And then the shared pharmacies allows those that are request another common ownership or contract pharmacy to conduct that initial interpretation of the prescription. So operational standards, so this was just to add who needs to be registered and who doesn't. So obviously these pharmacies can outsource to other pharmacies, if they have those contracts or have the same ownership, they need to have that electronic file or telecommunication. And the exception here is that all need to be registered with the state board except if there is a non-resident pharmacy that is not planning to ship, mail, get drugs into the state of Colorado, if they're just doing maybe the initial interpretation, they don't have to be registered with the state board. Responsibilities of the originating pharmacy. This was changed to state that so when you send the prescription off to another location for them to perform some part of the dispensing process, that you need to document all this information. However, if it's a subsequent dispensing or a refill, you don't have to document that each and every time. So all this information does need to be documented on the original prescription, unless if it's a refill, it does not. All right, pregnancy and lactation labeling. So as of July 1st of this year, there's going to be new formats. So the FDA is actually doing away with the pregnancy categories. So any drug that comes on the market from July 1st on, they're going to need to use this new format. And the drugs that are on the market currently will gradually be phased into using this new format. So the purpose is to really just reorganize information for healthcare providers, provide content and formatting in a more consistent way, and the new labeling is really just going to focus on potential benefits and risks for mother, fetus, and breastfeeding child. There's going to be 3 subsections: pregnancy, and this is going to focus on dosing and potential risks. Also, if women have had any issues or problems when they were taking the drug, so exposure risk, and there's a registry for it, this is where it's going to be listed. So patients, healthcare providers can actually go to that registry to find out what issues or problems women who were pregnant were having when taking that medication. Lactation is just indicating the amount of drug that passes into the breast milk and any effects, if any, on the breastfed child. And then lastly, there's going to be a subsection for risk reproduction for females, but also as well as males. So specifically, the pregnancy and lactation subsections are going to look at risk summary, clinical consideration, and they're really going to focus more on data. So human data, animal data, and that's going to all be in that section. So really what they're doing is taking away those pregnancy categories that give kind of a false sense of security. We used to just look in a book and say, yep, it's B, it's good, you can take it. But now it's really forcing the clinicians to read the information and make a good educated decision on whether or not that medication should be prescribed to the patient. All right.